Hi, I'm Matthew Herzberg, and this is the Myopia Mindset. This is your weekly shot in the arm for all things inspiration, education, and motivation on your path towards success with myopia management. And I am super happy with this episode. I've got another absolute legend in orthokeratology and myopia management, Dr. Julio Arroyo. He's originally from Spain, but he's based in Woodlands, Texas. His expertise spans everything from non-surgical refractive correction of myopia, hyperopia, astigmatism, pediatric eye care, glaucoma management, and holistic vision health. He's a fellow of the AAOMC and the International Academy of Orthokeratology and Myopia Control as well. Julio, welcome to the program.
Hey, thank you so much, Matt. It's great being here. Absolutely. Thank you.
Yeah, and we are going to be talking post-LASIK orthokeratology, and this is a subject that is, a lot of it is way over my head, and I was like, who do we know that is like the best person to talk about this? Julio is at the top of that list, so I asked him to come on. So we're going to learn all about post-LASIK Ortho-K in this episode, so get out your pens, your spiral notebooks, get ready to take notes, because we're going to be learning a lot in this episode. But Julio, before we get started, if anybody has any questions for you about anything we talk about in this episode, how can they reach you online?
Well, I mean, we are on social media. We're on Facebook. You go Eye Health Consultants. That's the name of our practice. The website, which is easy to remember, is sleepandsee.com, right? Sleepandsee.com. That's probably the easiest way to see the website. And again, we're Facebook, Instagram, as well as Eye Health Consultants. Of course, you can find me under my name as well, Julio Arroyo. So I love to connect with colleagues and like-minded doctors and clinicians, and that's love to talk to you if I can help in any way. Absolutely.
Awesome. Yeah, and also just a reminder, if you enjoy this episode, if you want more from the Myopia Mindset, please consider becoming a paid supporter. You can find more episodes like this at myopiamindset.com. And if you want to support everything that we're doing here, you'll get extended versions of every episode. You'll get bonus episodes each and every month. So if you nerd out about this stuff like we do, then please consider becoming a supporter. Myopiamindset.com is how you do that. Okay. Julio, before we get into the specifics of post-LASIK orthokeratology, I want to ask about you, your journey, and your practice, because I think that sets down a good foundational layer for the topic. So let's start with how you became interested in myopia management, and give us like an overview of your practice.
Yeah, and everybody loves to talk about themselves, and you think about the other person. They're bored about you talking about yourself. So I'll try to make it short, then we'll get to the point, because people probably want to get some tips, information about the topic. But I doctorate. I did I moved from Spain here, graduated with an optometry degree in Spain, and moved here in 1996. Graduated around 1999. It was kind of an accelerated course. I worked in many different settings for 5 years. Eventually, I opened Cold Turkey, called 2005 Texas Eye Consultants, in a very small hole in the wall, in a kind of very secluded area. And, I was seeing 3 patients a day, 7 patients a day. Eventually grew, and while I was at this hole in the wall, it was like 1,000 square feet. I said, you know what? I need to get into Ortho-K. And it was just like an inner calling, so to speak. It was just, this is what I'm going to do. I am going to get into Ortho-K. I want to learn Ortho-K. So I called everyone I could. I took every course I could take. And many times those courses taught me what not to do, what to do. But it was just the journey. We all have our own journey. And that's how I started in 2008. I went to one of these meetings. Sorry, let me turn these off. I went to one of these. Actually was Vision by Design. No, it was the Academy. It was the Academy. Anyway, the point is that I bought a topographer, and that topographer was linked to a lab that turned out to be my lab, the best decision I could make. It was a fluke, but it worked out great. So I started doing Ortho-K, and I went all in. So basically, you want to do Ortho-K, you put your heart, your mind, everything at it. So I started looking into marketing, promoting. I mean, obviously, you turn your practice around. It's all about Ortho-K, right? You start creating your brand. So that's how I started in 2008. At some point, I had two practices. I opened another call in 2011. And of course, that was in an area here in the Woodlands it was growing a lot. It was a lot of families with small kids. So I thought, well, this is going to work out great, right? Because there's so many kids, right? So many myopes. Well, it didn't turn out that way because most of my patients were coming from out of the Woodlands. I was having patients traveling 2 hours, 3 hours, because the power of social media, really. But I wasn't really attracting as many patients from locally as I thought. Still worked out, still we make it happen. Eventually we were signing up 30 patients, 30 new Ortho-Ks per month. At this point, I've done thousands, but it was extremely busy. I mean, it got to a point where we were signing 5, 6 in a day. So it became very, it just that this small wheel takes inertia and eventually, and some people say, well, how do you learn to do Ortho-K? They say, well, you learn by doing it. So, and that's what I did. I did a lot. And many times, to be honest, I didn't even know what I was doing, particularly at the beginning, right? And you get lucky, and then you understand how you got lucky, and then how were you so naive? How do you have the audacity to try these cases? And it didn't work, but many times it did work, and nobody was doing it. Like hyperopic Ortho-K, right? Nobody was doing hyperopic Ortho-K at the time. Matter of fact, very short story. Remember this lady? So we signed her up, and she called her ophthalmologist, and the ophthalmologist said, "No way in hell that exists. That's wrong. They're lying to you. They're probably con artists. It doesn't work." She called me all upset, saying that I was just cheating her. That we were. So this is in 2011. So that's how out of the box it was. It was almost woo. So patients and doctors wouldn't understand. What do you mean? I mean, you don't do this for hyperops, right? Yeah, what do you mean? We're doing it, right? So at this point, 50% of the practice is hyperopic Ortho-K. And connected into LASIK, problem is that many of these folks that had LASIK, they get into their 40s and say, well, I did LASIK for a reason. I hate glasses. I want to have the freedom. Yeah, I'm going to have LASIK again. But these are presbyopes. So what do you do with them? Well, you kind of go the other direction. They have, they have their flap or a myopic, they had a myopic correction, flat corneas. So you kind of reverse it and make it a steep to give them some power up close. So anyway, that's a short story.
Yeah, let's transition then into, can you explain what the primary difference is in a post-LASIK orthokeratology case and how it differs from traditional Ortho-K? Because, when I think about, Ortho-K as we understand it, and then doing that on a post-LASIK patient, it's like to me, that seems like almost hands off, like somebody at your level. I want you to walk us through that. Like, what is the primary differences between post-LASIK Ortho-K and traditional?
Well, first of all, we can talk about my primary fear or concern and the primary difference. And, believe it or not, Matt, if you have post-LASIK cornea, those corneas are thinner by definition. So you can mold thinner corneas better than you mold thicker corneas. If you have a cornea that is thick, I was actually taught the opposite. It's not like LASIK. It doesn't work. Oh, well, you don't have a thick cornea. You can't have LASIK. Well, it doesn't work that way. As a matter of fact, when we see thin corneas, we know that's going to work so much better. So in reality, molding corneas that are post-LASIK is actually easier from the standpoint that they are thinner by definition. Mm-hmm. At the same time, you have one major concern, which is the flap, right? So you have a flap, and imagine if that flap kind of gets out of place, and all of a sudden now you have a free flap or something. There's certain liabilities that you incur into when you're doing this on LASIK patients. I don't know what this is another. This is topic for a different conversation, but I know the FDA here in the States and the US approves Ortho-K within certain rates. I think it's 5 diopters of myopia, 1.5 diopters of astigmatism, and a certain diameter for the lens that treats that cornea. If you are out of those ranges, then, well, the FDA is not covering. So we are doing it like off-label, or I don't know how you call it. So you have a LASIK cornea, a post-LASIK cornea, and you treat it for, let's say -3, and we have many of those, right? Well, you're fine because you're within the boundaries of the FDA approval. So, well, you have a free flap. Well, I'm sorry, but you know what? We're still within the range, right?
Right.
So I wish that was the case, but many times you got to go the opposite direction. You got to go into hyperopia, and hyperopia and myopia are two different animals, right? So
Right.
again, from standpoint, can you mold corneas that are post-LASIK? Absolutely, they mold so much better. From standpoint of liabilities, hey, you know what? You better make sure you do stuff and you educate the patient so you don't get a free flap. I think that's still very hard. It's very unusual, very atypical. I knock on wood. My God, I never seen a free flap or anything. But that's my main concern. And some doctors they scare away from doing it for a good reason, because there's some liabilities involved, right?
Right. Yeah. And what kind of patients are we typically seeing that are seeking out Ortho-K treatment after LASIK? I've seen a variety of LASIK patients where, you the first thing you think of is the example you used where they expected this result to last, for the rest of their lives. It didn't. But then you also see these cases where they've had, these horrible things happen because of LASIK. And I'm not here to talk about whether LASIK is good or bad. I'll leave that up to every optometrist in their own way. But so what is your typical patient that you're seeing? Are you seeing the first variety or a combination of both?
Well, first of all, in terms of age, these are usually over 40, although we have a handful of patients that are under 40 and they, being the last. And like you said, people have these mindset, well, I do LASIK and then for the rest of my life. We all know that. As a matter of fact, they sign there's a disclaimer, well, you may need glasses again in the future. That doesn't guarantee that you're not going to need glasses. We've seen patients that are loving it. They love LASIK. And, for 10 years, it went great. And what I see a fundamental pattern that happens in all LASIK patients is that all of these patients, or most of them, to a certain extent, I would say even up to 70%, they have different degrees of dry eye or, ocular surface disease, or whatever you want to call it. So many of them, it's just dramatic. And some of them have their life ruined. I don't want to scare anyone here. I'm not against LASIK, but it does happen. We know it does happen. Of course, other things that we see are patients with post-surgical ectasias, the cornea kind of bulges out. And then now they have 20 diopters instead of 3 that they started with. And now what you do with you put them with sclerals and they go. I mean, I remember this beautiful girl, 30 years old, executive, and she's a minus 20 something. And she had dry eye as hell. Let me turn these off. Okay, there you go. She has these horrible dry eyes. So you're fighting not just the refraction, you're fighting the poor tears, and you're trying to make them so they don't get red eyes all the time. It's just now, we're doing different things for dry eye. We're doing platelet-rich plasma growth factors, amniotic membranes, APL, radio frequency. All these things that we're doing are a godsend, and they really help these people. But again, the point is that usually it's patients over 40. And these are people, like you said, that don't want to wear glasses, and they're okay putting something at night. Yeah.
And when they come to you, what kind of state are they basically in? Because I can imagine that after going through, this expectation, they are exasperated with the fact that they don't have the results that they were expecting for life. So talk about setting expectations with them, because I have to imagine, like you said earlier, you got to have informed consent. You got to make sure they understand everything about the process. So talk about setting expectations with these patients, because obviously you can't guarantee results given the circumstances.
Yeah, and you see, Matt, I don't think there's a different. So setting expectations, of course, they understand they have to wear those molds at night, right? I mean, when they sleep. So they know that, and they know it's going to happen every night. For some people, some individuals, they can get away just by doing it 3-4 times a week, and they're happy with it. If we're doing one eye distant, near. We play with it. Sometimes they wear every other night for the non-dominant eye. I mean, there's all kind of variations. It's just a process. When you've done thousands, you have different combinations there, right? Different protocols, different algorithms that you use. But as far as the expectations, they're not very different, to be honest, to patients that have regular Ortho-K. The expectations are the same. And we talk about adaptation, in particular when you have to correct distance and near, you do have to talk about adaptation. There's going to be an adapter. Believe it or not, LASIK patients don't have as many issues anymore because they already went through the stage of glare, for instance. Glare and flare. Glare is a big issue, right, in Ortho-K, also in LASIK, but they already had that problem. They already went through that process. They already went through the process of disappointment and frustration because, hey, you know what? I paid $5,000, whatever it was, for LASIK. It didn't last long enough, and now what do I do? By the time they come to us, they're already past that stage. So they are more into the, all right, what can you do for me? I'm excited again. All right, I didn't know this existed, so now I can get rid of my glasses again, right? So they're excited again. So that's a good thing, right? So they adapt well, and they're easy to mold. We can talk about design and what do we do?
Let's do that. Yeah, let's transition into design because you're an elite wave user. You're just designing these custom lenses for your patients. So let's talk about the design aspect of it and the challenges that you face because you're having to design a custom lens for each patient, correct?
That is correct. Yeah, I do. I didn't know if I was supposed to say here who I use, but I use Wave 100%. And I do because it provides me the freedom to design exactly what I want without any limitations, right? And it's a very easy platform to use, and I can do it in my own time. Sunday nights, I'm designing 40 molds, and I just do it whenever, So it's really good. But anyway, going to design. So that there are certain things, you have a cornea that has been moved and have been changed. Centration is a big issue, right? Centration is always a challenge. I no longer have centration issues. I haven't had centration issues in a long time. It's very unusual to have centration issues. Those, you see those blogs where people talk about how to improve my centration, look at this and that. Centration is most of the time, it's no longer a problem. But what I do for most of I'm referring here to Ortho-K for hyperopes in particular. Mm-hmm. Mm-hmm. I'm already out of the FDA range anyway, so I might as well go out of the range completely. So it's not covered by, or it's not protected by FDA standards or approved, whatever. So, hyperopic Ortho-K in particular. So, I design all of this in a what we call a translimbal design. So these are molds that are larger than HVID, they're larger than the cornea. So we go out about 1.5, 2 millimeters larger. And that creates a skirt, the landing is still the landing on the cornea, but then that creates sort of wings that go a little farther and create clearance under the limbus. But that creates this capillary attraction, and that capillary attraction is what holds the mold in place very, very well. It's very well centered, never moves. And it's also extremely comfortable. So these older folks that complain about, comfort and whatnot, it's no longer an issue because they're super comfortable for the most part. So that's one thing. Going larger is one thing. Of course, there's technicalities that are related to the software that we use at Wave, where I could explain how I set the certain parameters of the landing zone, of the treatment zone, and all of that to make it happen. I can use aspheric designs that reverse designs that incorporate an aspherical, instead of spherical, aspheric. So it's a transitional curvature that moves throughout the optic zone. And we do that for different reasons. One of them is because we want to avoid something that we call central lakes or central islands, where the molded pattern kind of collapses. It doesn't get all the way to the center because of different reasons. But, when we incorporate that aspheric design or aspheric factor, many of those products go away. So there's a lot of technicalities, a lot of little subtleties as you design, but we design larger for sure, and that accomplishes many things.
Yeah. Can you go more into the design aspect and challenges around, because you're essentially, working with an altered cornea. So what do I imagine you have to be very careful when you design the lens. So can you go more into that? And if you need to get technical, so go for it.
Yeah, and again, the main concern that I find in these patients is, addition or binding, right? So the patient gets up in the morning, they have sort of dry eyes, and now they have to take those out, and it's kind of stuck to the eye. That binding is very scary, right? What if they yank it out, and then part of the cornea comes with it or something? It sounds savage and horrible. And again, I'll knock on wood again. I've never seen that. And it's very, very unusual. But one thing that you would do that you always keep in mind when you design LASIK, post-LASIK Ortho-K, different story if you have a PRK, because PRK and LASIK are two different animals, right? Question is the flap. The flap is the liability. The flap is the concern. But you want to make sure that these molds are loose in the sense that they move well. Then there's less chance for binding. So when they get up in the morning, the mold is moving. It's not stuck, right? It's not there. So we got to go through training with these patients. Well, the mold is stuck in there. Just make sure it moves. So we go through a protocol, have a magnifying mirror, make sure that you see the edge, make sure it's moving. And if it's moving, then you take it out easy and with confidence. If it is not moving and it's stuck in there, don't attempt to take it out. You're going to hurt yourself. You could hurt yourself bad. So the staff knows, all our team knows, they have to go through this process every time we train people, but we train patients. But the designs have to be in a way that they move, that you have a guarantee that they're not going to be stuck in there. You don't want tight designs, right? Tight designs are the worst problem. It's not flat. Flat doesn't hurt the cornea. It's tightness. Tightness is what creates the metabolic SPK. The pathologies of the cornea as a result of Ortho-K happen more because of tightness rather than flatness. And tightness is what creates the lack of tear circulation. And that eventually creates all these metabolic issues because there's no oxygen going through. So that creates an acidity. And, it's a process where those cells get toxic. And that's how you get SPK, you get keratitis, and you get all these problems. But anyway, so you go flat, make sure the mold is moving. And you are very diligent at explaining to the patient. Make sure you don't attempt to take it out. If the mold if the mold feels like it's stuck, right? Those I would say that would be my main tips.
Gotcha. Yeah. And what kind of timeline are we typically looking at, like in relationship to traditional orthokeratology? Do you have to work slower than, because you were saying that the corneas are actually easier because they're thinner? But given everything that you're doing, do we, compared to a typical Ortho-K patient, do we expect treatment to take longer over, and you have to monitor it more closely, or can we expect similar kinds of results as a traditional Ortho-K patient?
Well, again, I think since these patients are older, I think they take longer. From the time we start, to the time we say, okay, this is a successful patient, that's a longer process than a young kid. That's what we all want to. We love kids. Kids are so easy, so straightforward. When we're dealing with adults, it's a different story, right? So from the standpoint that they're mostly adults or patients over 40, they're going to take longer just because we need adaptation. We're dealing with distance and near, and we're dealing with tear issues. So the tear dysregulation problems. The fact that you're dealing with distance near, the fact that they're post-LASIK, all these things make it more of a longer process in terms of we have to see them more closely. We have to make more designs. Sometimes we have to change designs. This is not a one thing. Oh, you pop it there and it works. For example, you might have a perfect patient. Perfect in the sense that you got great results. You see them in 2 weeks. They're doing great. You see them again in 1 month because, I usually do, by the way, 2 weeks, 2 months, 3 months. So that's the way we do it. So the patients, the staff dispense them. I don't even see them there. I see them 2 weeks later. I used to see them in 1 day, 3 days, 1 week. It was, then we realized you don't need that. So I see them in 2 weeks. I see them 2 months and 3 months. Unless there's changes to be made, unless they're not doing well, where we have to redesign. So we redesign and see them 2 weeks later. So there's all kind of different algorithms there. But the point is that we see them more often. That's one thing. you have to, and then I was saying, I'm sorry, kind of got ahead of myself, but so you have a perfect patient, you get +2, dominant eye, right eye, you make them perfect and they're great. They're, hey, you know what? I love this. I can't believe it. This is like magic, man. You take a picture with them. They love you. They hug you. And then you see them again. Well, we'll see in 2 months and, or 1 month, but they come back and all of a sudden, your over refraction was planar for the dominant eye, -150 for the left, which is very typical. And then all of a sudden they're +1 and +50, right? Mm-hmm. So I said, well, what happened there? Well, there's this drift. So, it's working very well in these corneas. All of a sudden, particularly LASIK corneas, they're more mobile, more dynamic, more unreliable in the sense that they behave in a volatile way. So all of a sudden, 2 months later, they're undercorrected, which is usually what happens. It doesn't happen the opposite. Usually undercorrected. And then you're like, what in the world? So, and I see that quite a bit. So at that point, you have to redesign. You need to validate the answer. So you have to ask the patient, you wore the molds last night, wore them for the last night straight. If I design having the wrong set of assumptions, I'm going to overcorrect you and you're going to hate your distance vision. So we go through a conversation. So many times, no, I'm just doing the same thing. I'm very diligent, this and that. And no, it's just that there's a drift where there's and something happens on the cornea that's an undercorrection. So those molds all of a sudden are underperforming and you have to redesign. So that's something that happens most often in post-LASIK patients than any other ones.
Yeah.
Not to mention RK. I do very, very few RKs. I have some successful RK, post-RK patients, radial keratotomy, the old cuts on the cornea. Savage, man. They were doing that before 95, right? And, there's so many people out there walking with these horrible corneas for people, right? So I attempted LASIK on those. Ortho-K on those patients post-RK, and those are even more volatile. That's crazy. You having, I got it, man. This is good. And they're happy. All of a sudden, they come later and, it's no longer working. So these corneas are not as reliable, I could say.
Right. Yeah, and that's fascinating. I mean, it makes so much sense. But when you think about it, because in traditional Ortho-K, you can see the need for adjustment if things aren't going according to plan, especially in those higher end cases. All right, we had a brief disconnect there, but we've got Julio back. We were talking about the importance of topography capture. So I'll just restate the question, and then we'll get rolling again, Julio. So, what I was saying before was that topography capture, in my experience, is one of the most overlooked aspects of Ortho-K, especially for the new to myopia management docs. I've been in practices where they don't spend time doing quality topography capture. They take shortcuts. And I have to imagine that, especially with post-LASIK cases, you have to really, really be good at topography capture. It's that much more important. So I want you to go into that if you can.
Yes, and as I was mentioning, Matt, I have 5 topographers, 1 in each room, just for efficiency purposes. Otherwise, it creates a bottleneck. We have 20 patients that day that require maps. Imagine just going through online, each one through the same machine. So we have 1 in each room, but on their portable handheld, and everybody in the office learn how to use them. But so that's what I think all topographers, they're amazing topographers out there. I don't know which one is better for what. I guess it depends on what technology, what design you're using. But they're all wonderful. I don't have the newest technology. I just have the one that worked for me. But you're right. I think there's something fundamental about designing. If you don't have good maps, it's like trying to cook a great dish and not having the right ingredients, right? I'm just going to get this, canned food and this and that and try to make the perfect risotto, or something, or paella.
Right.
You need to have the right ingredients. So the map, the corneal topography is the most fundamental piece of data that you need to make sure you ensure success in orthokeratology. But even beyond that, I think there's one fundamental thing that the most critical aspect of what defines a good map is a reliable map. And reliable map is not necessarily, okay, it doesn't have any zigzag lines, doesn't have any blood dot mucus there showing. Maybe those things are not as important as having the right estimation of sagittal height. So many of these topographers, I mean, they should when they should, right? So you're taking a map and it's going to give you an estimation of that curvature, and it's going to give you an estimation of the sagittal height. And so we're talking to, the podcast is directed to clinicians and practitioners. Everybody understands what sagittal height is. And I've seen in the past, particularly in my beginnings, where I was getting these double rings, horrible central islands, tight fit, and I didn't understand why. What was I doing wrong, particularly when there's astigmatism involved, this and that. And that is because the machine, whatever machine you're using, it will shoot at a certain point, right? You have to shoot at a certain point, and that certain point where you shoot is so critical because that's going to give you the estimation of sagittal height and eccentricity, all this good stuff, right? So what I do is I have a rule where we have the keratometer, the autorefractor autokeratometer. So I capture that, and then I'm going to compare the autokeratometer to K readings versus the topographer K readings, right? So they have to sort of match, though they have to be in the same ratio every time. Because like my autokeratometer is usually a little steeper, like 0.50 versus my topographer. But I know that, and it's always the same. But it is all over the place, and it doesn't match. It doesn't make sense. You have the wrong topography. So you have to create your own rules, your own protocol to make sure that you get the right eccentricity, the right sagittal height, and that is so fundamentally critical when you're going to design. If you got it wrong, chances are you're not going to be successful, and you'll be fighting with design after design after design. Trying to improve that when all of you have to do is just to have the proper data, the true data.
If you're interested in getting the rest of the episode, consider becoming a paid supporter of the Myopia Mindset. In addition to an extended version of this episode and every other episode that we do, you'll also get access to exclusive monthly bonus episodes of the Myopia Mindset. And I know you're interested. You've made it this far. You can do so on our Substack, myopiamindset.substack.com. I'll see you at the next one.